Hi, everyone. It's really nice to see everyone here today. Thank you for joining this really special presentation that is from the Youth Outpatient Substance Use Program. My name is Dr. Petra Steinbushel. I'm a child and adolescent psychiatrist and the director of the UCSF Child and Adolescent Psychiatry Portal. And we are delighted to have Drs. Veronika Mesheriakova and Dr. Emily Tejani today to talk about providing medical care for youth with opioid use disorders. So by way of introduction, Dr. Mesheriakova is board certified in pediatrics and adolescent medicine and completed her board certification in addiction medicine. She is an assistant professor of pediatrics at UCSF, the director of the UCSF Youth Outpatient Substance Use Program, and the UCSF Youth Addiction Management Professional Training Program. And she's the only pediatrician in San Francisco with medical center privileges to practice addiction medicine. Dr. Mesheriakova attended medical school at the University of South Dakota, completed her residency in pediatrics at Yale New Haven Children's Hospital, and fellowship in adolescent medicine at UCSF. She is the recipient of grant funding through the California Youth Opioid Response. Dr. Tejani is a physician with triple board certification in child and adolescent psychiatry, adult psychiatry, and addiction medicine. Dr. Tejani has a private practice in Marin County, California, where she provides psychiatric evaluation, second opinion consultation, and co-occurring disorder treatment, including psychotherapy and parent guidance to youth and adults with psychiatric and/or substance use disorders. In addition to her private practice, she is a consultant to the UCSF Youth Outpatient Substance Use Program, a role in which she supervises child psychiatry fellows during their clinical rotation through the clinic, and also actively contributes to the clinic's multidisciplinary efforts to expand clinical programming and access to care for youth with substance use disorders. She regularly teaches psychiatry didactics at UCSF and also frequently speaks at conferences and in other settings on topics related to youth substance use and co-occurring disorders. Outside of her direct clinical network, she is a consultant to the SAMHSA-funded Opioid Response Network, a role that involves providing education and training about addictive disorders to physicians and other clinicians throughout the state of California. She has substantial experience providing consultation to community pediatricians, primary care physicians, and clinicians at residential treatment centers and intensive outpatient programs. Dr. Tejani attended medical school at UC San Diego and completed her psychiatry residency and fellowship at Yale. During her time at UCSD and Yale, she participated in international NIDA-funded clinical trials and epidemiological research studies related to opioid use disorders, combined pharmacologic and therapy treatment, and harm reduction. We're super excited to hear this presentation and really want to make this as interactive as possible. And so I will be moderating and monitoring the chat feature that we want to use as liberally as possible in order to make this really interactive. And we do have some case presentations that will be part of the presentation, but want to embed some time for questions and make sure that we can address those as they come up. We will likely have pause points for those questions. And if there are questions that come in that we're not able to cover during the time that we have, then the speakers will be following up to respond to those questions after the webinar. And also just want to let folks know explicitly that this is being recorded and hopefully for wider use and dissemination later. So with that, I'll turn it over to the speakers.
Thank you so much for that kind introduction, Dr. Steinbushel. I'm first to speak. I'm Dr. Veronika Mesheriakova. Thank you so much for having us. And we've divided this presentation into two parts. I will start and then I will hand it off to Dr. Tejani to speak more specifically about co-occurring psychiatric disorders. So some of our objectives today are really to describe trends in opioid use among youth, as well as overdose death trends. We'll talk about barriers to youth receiving appropriate treatment. We will also talk about evidence-based treatment modalities. I think that's really an important point. We'll talk about medication treatment for opioid use disorder. And then of course, Dr. Tejani will take a deep dive into the implications for youth with co-occurring psychiatric and opioid use disorders. Now, we wanted this to be interactive, so we are trying out a fun new feature through Poll Everywhere, where I'm hoping all of you can text some answers to see who we have joining us today. So if you would like to participate, I would highly encourage it. And all you have to do is get into your text messaging platform and then dial to the number 37607, text VM612. You can see these instructions on top. And then you only have to do that once. And then after that, you'll just be able to text A, B, C, D, or E and provide your answers to all of the other questions that we have posted on Poll Everywhere. So I'm going to go ahead and do mine. So I'm going to enter 37607. And to that number, I am texting VM612. And then I will answer that I am a physician, D. So let's see. We should be able to see results in real time. Maybe, if all things work. We got a bit of a delay. And the first question is always the practice question, so take your time. And I have a chat here that says, can't see. Okay, let me type the instructions. Text VM612 to 37607. Then text your answer. Admittedly, this is my first time actually using Poll Everywhere in a live presentation, so it may still not have had many of the kinks worked out. All right, well, while everybody's practicing that, we'll see if we can go back to this question once everybody has submitted an answer. But for now, we'll move forward to our next slide. Well, let's see. So this one asks about which town and city do you practice in? And this one seems to be working. So that's exciting. It looks like people are working. I'm going to type mine in. There we go. Prevention specialist, San Jose, Puerto Madero. These word clouds are always kind of interesting. We have people from Oakland, Waterford.
And just wanting to jump in, I don't know that folks can see the locations. The screen on the screen share is actually not showing those.
Oh, really? Okay, well, the Poll Everywhere may not be a functional feature today. So we will, but you can see the questions, but not the answers.
Mm-hmm. I'm wondering if we should just invite folks to type into the chat just so that we can all see, both your professional training and location.
That would be great. Apologies that the feature isn't working. So I'd love to see that in the chat instead. And that's what we'll do for all the other Poll Everywhere questions. Okay, in the meantime, I'll just move on and then we'll plan to use the chat for all the subsequent questions. And I'm getting some chat responses. All right, I see a physician from San Leandro, a pediatrician from San Francisco, love it. MD from Fremont. Great. Okay, so our next question is, how confident are you in your ability to provide guidance on evidence-based opioid use disorder treatment to youth and their families? And you can type in okay, I see a not confident, great. Very confident, great. Keep the answers coming, I love it. All right, so I'm gonna start by just talking about a few cases that these were actual cases of patients that we've worked with in our program. And I'm hoping that the answers to these cases become evident as we move through our presentation. So case one is a 14-year-old patient that discloses that for the past month, she's been experimenting with oxys that she buys from her friend at school. She doesn't think she's addicted and is just having fun. She's planning to go to a party this weekend and already bought a few pills to use while there. Her parents are not aware of this, and she doesn't want them to be. So what would you do? And these are, for now, rhetorical questions that I want you to think about, and hopefully as we go through the presentation, we'll have some answers for these. Okay, case number 2, the parents of a 15-year-old patient come to you because they found out that their son has been using Percocet that he found in the family medicine cabinet. He's otherwise doing well in school, is getting along with his family, has no symptoms of depression. But after this happened, a family friend suggested that the parents send him to rehab in Utah for treatment. And the family is coming to you as their trusted provider, asking you what to do. So think about how you might respond. And finally, case number 3 is a 17-year-old boy with opioid use disorder who's being treated with buprenorphine and has not used opioids for 4 months. Unfortunately, he experiences a recurrent episode of major depressive disorder with suicidal thinking and needs to have a psychiatric hospitalization. Unfortunately, the psychiatric hospitals in your local area are not willing to continue his buprenorphine and will not accept him until he is off this medication. How would you proceed at that point? So just planting some seeds here for you all. So I'd like to start with a little bit of epidemiology about what's been going on with prescription drug misuse among adolescents. And the good news is that largely prescription drug misuse has been declining over the past few years. And a lot of speculation has been going around as to why this is. And honestly, the answers aren't fully clear and probably multifactorial. But either way, this is a positive trend. And here we can see the epidemiology of opioid use disorders, so an actual diagnosis of opioid use disorder in the past year among people aged 12 or older. And the gray line here represents adolescents aged 12 to 17. And as you can see, they have among the lowest rates, and the rates seem to be declining. Unfortunately, what we are seeing is that drug overdose rates are actually on the rise. And the red arrow is pointing to the age group of 15 to 24-year-olds. So although the use of prescription drugs seems to be declining, death rates are going up. So this continues to be a significant issue. And what we think is happening is that overdose rates are highly influenced by the presence of synthetic opioids like fentanyl and carfentanil that have been adulterating the supply of opioids that people may buy on the street. So let's take a look at detection and treatment of substance use disorders among youth in general. What we know is that, unfortunately, fewer than 50% of pediatricians routinely screen adolescents for substance use, and few are using a validated screening tool to do so. And even when screening does occur, pediatricians tend to underestimate the severity of adolescent substance use problems. And I think this largely comes from the fact that adolescents themselves very rarely see their substance use as problematic. Just like in the cases I presented at the beginning, most adolescents will come into care and say, this isn't a big deal, I'm just having fun, don't overreact. And so it's, I think that probably influences a lot of providers as well. And there was even one study that revealed that only less than 5% of patients with problematic substance use were correctly identified. And unfortunately, even if screening happens and we're working to identify problematic substance use, up to 20% of patients receive no intervention, even if problematic use is detected. And so what does that mean for youth addiction treatment as a whole? Well, what we know is that a significant number of youth aged 12 to 17, almost 2 million, are affected by substance use disorders. However, the vast majority receive absolutely no treatment. And here's an illustration from a study that looked at rates of treatment for alcohol problems, illicit drug use problems, or problems that, involve both alcohol and illicit drugs. About 10% of adolescents or fewer are actually getting the treatment that they need. So you might say to yourself, looking at this data, well, perhaps youth aren't getting treatment because their substance use disorders aren't that severe. Maybe they're just, not affecting parts of their lives. Maybe this is more experimentation. But what we see is that even after a serious opioid overdose, something that brings youth into emergency departments, they still don't get the treatment that they need. And there was one prospective cohort study that looked at all non-fatal opioid overdoses in Massachusetts between 2012 and 2014. And it identified 195 youth who presented with opioid overdose and showed that fewer than 5% of adolescents received medication for treatment of opioid use disorder in the 12 months prior to their overdose. So this means that either their opioid use disorder wasn't identified, or if it was, very few of those youth were getting appropriate treatment for that use disorder. And looking at what happened after that emergency room visit for serious opioid overdose, only 8% of adolescents received medication for treatment of opioid use disorder in the entire year after their overdose. So even kids who are coming to the ER with serious overdoses really are not getting evidence-based treatment. And so there's a couple of things that contribute to this. So one, program availability is limited. In between 2003 and 2010, less than 36% of addiction treatment programs in the US offered services to adolescents. And actually, when that study was done, the number of programs actually declined each year during that time period. And this is really important because adult addiction treatment programs often don't take into account unique needs of adolescents. And I think the other barrier that we see is that medical education on substance use and addiction is very much lacking in our system. So when we look at what happens in medical school curricula offer a total of 12 hours of education on substance use and addiction over the entire 4-year program. And only 12 medical schools require a course on addiction. 45 medical schools offer an elective course on addiction. And what we see is that medical students' attitudes about people with addiction tend to become increasingly negative as they progress through training. And I must admit that when I was a medical student, this was the case for me. And in reflecting back on that, I think the reason that happens is that the training we get is really inadequate. And so when we're working with people with addiction, it feels hopeless. And that hopelessness, I think, influences how we feel about working with people who are struggling with this disorder. And when we look at training in pediatrics residency, the ACGME has very few requirements for training in this area, right? So this is an example, and it just says instruction and experience in pain management, if applicable for the specialty, including recognition of the signs of addiction. And in my pediatrics training program, I got very little training in substance use and addiction. I received some training in screening and brief intervention, probably a total of 4 hours over my 3-year training program. So with this in mind, what can pediatrics providers do, right? Because I'm sure that many of you will be seeing youth who are struggling with substance use. And my advice starts with routinely ask about family history of mental health disorders and substance use disorders. So when I'm working with residents and fellows and they're doing annual physicals, I tell them, great, I'm glad you're asking about family history of cancer and diabetes, but really what we know is that adolescents are most likely to be affected by problems that involve mental illness and substance use. And so getting that kind of family history will get you a lot of bang for your buck. I absolutely recommend that you routinely screen all adolescents for substance use using a validated screening tool. And in fact, there was a study done by Sharon Levy at Boston Children's looking at comparing what providers that used a validated screening tool to providers that just used, a conversational or even a HEADS framework to assess for substance use. And she found that only about a third of adolescents with problematic alcohol use were identified if a validated screening tool wasn't used. So that is definitely a strong recommendation. I would also encourage all of you to understand what actually goes into the diagnosis of a substance use disorder. Learn about evidence-based treatment approaches, and know where to refer patients for good evidence-based addiction treatment. And so today, a couple of things that I'm hoping you're already getting out of this seminar is I will talk about how to diagnose substance use disorders, we'll talk about evidence-based treatment approaches, and we'll talk a little bit about where you can refer patients. So already you're doing a lot. So let's talk a little bit about screening. Screening and brief intervention can be a lecture in its own right. So this is very brief. But again, universal screening is recommended using a validated screening tool. And there are several options for tools you can use, including CRAFT, S2BI, which is an online or iPad-based tool. There's the BSTAD, as well as the NIAAA Youth Alcohol Screen. In our clinical practice, we are using the CRAFT. So I'm going to briefly show you what that looks like. So this is the most recent version of the CRAFT, and the most recent addition to this questionnaire is questions about tobacco and nicotine products, including e-cigarettes. And this comes in a version where you can either give the questionnaire directly to the patient and have them respond, or there's a provider interview version as well. So in our clinic, we generally have patients fill this out while they're waiting for their provider on their own. And what's nice is there is actually a correlation study looking at what do the results mean, right? So when we look at this questionnaire, patients will answer these questions 5, 6, 7, 8, 9, and 10, and then you count up how many of those they answered yes to. And the correlation study showed that if patients are answering 4 of those questions with a yes, the risk that they have a substance use disorder at that moment is 92% of people will have that at that time. So this is a good reminder that if they're answering yes to a lot of those questions, the next step really is to ask yourself, does this person have a use disorder, and make that diagnosis. All right. And a few comments about making a diagnosis. I just want to point out that there's differences between the Dsm-4 and Dsm-5. So you might, when looking at the literature or speaking to providers, hear about substance abuse and substance dependence. And those terms are really, at this point, antiquated terms, and I think less clinically useful than what we're using now based on Dsm-5. In Dsm-5, there's one unifying diagnosis, substance use disorder, and it's graded mild, moderate, or severe. To me, this is much easier to comprehend. And what's nice is that, I have a little Dsm-5 pocket reference guide that I can refer to when I'm thinking about this diagnosis, but you can also find these diagnostic criteria online. And there are 11 of them, so it's a lot to remember. However, what I always tell trainees who I'm working with is really think about whether the substance use is affecting major aspects of that patient's life, right? And when you think about, well, what's most important in your own life, right? Family, occupation, and what you do outside of work, right? So really, if all you can do is sort of think about it in that way, you will be able to sort of determine whether a diagnosis is present, even if you don't know the nitty-gritty details of these 11 criteria, right? So if the patient is constantly fighting with their family about their substance use, if they're having problems with their significant other because of their substance use, right? That's affecting their family relationships. If the patient is struggling in school, maybe is not going to school, grades are dropping, that's involving their occupation. And maybe your adolescent patient used to be an avid, track runner, and all of a sudden they've dropped all of their extracurriculars and all their sports, and most of their time is really spent using substances, right? So really thinking of it that way. And the other thing I would add to that is for adolescents, getting collateral information on these things, I think, is absolutely essential. Again, because adolescents tend to underestimate and underreport the severity of their problematic use. And so asking family members or caretakers about these things is going to really help you. And so I just want to talk about general treatment principles as well. And this is going to be really helpful for you as you're guiding families. And what we know is that most youth with substance use disorders will benefit from a combination of medical and psychosocial interventions. And the level of care should be individually chosen and be the least restrictive possible to meet that patient's needs. So our case that we presented at the beginning about a kid whose, family friend said, parents should just send him to Utah to residential treatment. That does not really sound like the least restrictive possible treatment option, right? So really this needs to be individualized. And medications for treatment of nicotine, alcohol, and opioid use disorders are widely available for adults and may be used off-label for adolescents. And we'll talk about that a little bit more. And just in the interest of time, I just wanted to give you an outline of what medical levels of care may be and what psychosocial levels of care may be. And again, most adolescents would benefit from both. So medical levels of care, drug testing, medications for some kids if they're using, alcohol or benzodiazepines, medically supervised withdrawal. And then psychosocial levels of care may include just outpatient psychotherapy, and then programs such as intensive outpatient programs where they may go to program a couple hours a day, 2 to 3 days a week. Partial hospitalization programs where they're more like a full-time job, where a kid may go to the program for the whole day, 5 days a week, and then just, spend nights and weekends at home. There's also residential treatment programs where youth will often go and live, as well as therapeutic boarding schools. And there are specific psychosocial treatment modalities, types of therapies that have some evidence to be effective. And I really like showing the results of this study that compared some of these different modalities to no treatment and showed that many of these modalities are effective. Some are more effective than others. And the most effective modality overall when compared is family-based therapy. So, and this is the reason that why at our program, we really focus on a family-based approach. Dr. Tejani will speak a little bit more about family engagement, but we absolutely recommend family engagement because of the evidence that shows that there's a lot of benefits to this. And I would encourage all of you as you're working with families to recognize some of the barriers that may exist to family engagement and provide counseling about how important it is for families to stay engaged in the young person's treatment. And so some really practical guidance for pediatricians is really educating families that, addiction is a neurodevelopmental issue, talking about when is substance use problematic as opposed to just normative adolescent behavior. And educating families that substance use disorders are not just something that, a kid does once, learns their lesson and stops doing, but it really can be a chronic, remitting, relapsing illness. And of course, counsel families about evidence-based treatment options and know about treatment programs that utilize these strategies. Okay. And specifically for opioid use disorders in youth, definitely remember naloxone. Naloxone is the opioid overdose reversal agent. It's safe, it's effective. Prescribe it to any youth who has reported ever using opioids. And in fact, I prescribe it to any youth who's using any drugs, because we know that certain street drugs are adulterated with opioids. So kids who think they're using cocaine or think they're using Xanax may actually be getting fentanyl in those products. And so I give this out liberally. And again, a combination of medication and psychosocial interventions is best. And in fact, the American Academy of Pediatrics released a policy statement 4 years ago now supporting pharmacologic treatment for adolescents with opioid use disorder. And looking at specific medication treatment options for youth and why it's important. Well, the number one reason is that it keeps people alive, right? So medications for opioid use disorder actually block the effects of illicit opioids and prevents people from having serious overdoses. It also increases retention in treatment, as well as other major benefits. It allows people to actually get back to life. And there are 3 FDA-approved medications for treatment of opioid use disorder in adults. One is methadone. However, methadone is very rarely used in adolescents. There's no controlled trials in adolescents. And methadone has to be delivered in methadone treatment programs, which has restrictions on age. And most methadone treatment programs will not admit people under age 18. So our go-to is usually buprenorphine naloxone, which is FDA approved for treatment of severe opioid use disorders in adolescents 16 years of age and older. And although the number of studies looking at effectiveness, specifically in adolescents, are few, there are some good studies showing improved outcomes for youth getting this treatment. And finally, Naltrexone is another medication that is often used both in the treatment of alcohol use disorder as well as opioid use disorder. Unfortunately, there are no controlled trials in adolescents. And the one open label case series has a very small N, but did show some positive treatment retention at 4 months and some positive substance use related outcomes. So it's an option. However, I would say the medication we use most frequently in youth is buprenorphine. And in our program, I just want to let you know as a potential referral for people for youth who you may be worried about. And basically, we're a multidisciplinary family-based program, and we see patients aged 12 to 25. And what's nice is that we're housed within an adolescent medicine clinic. So when patients come to our clinic, it's not like they're coming to, a drug treatment program. People in the waiting room in our clinic could be there for their annual physical, their sports physical, contraception, or substance use. We offer medical services, including the urine monitoring. We prescribe medications for treatment of addiction. And we also offer psychosocial services as well, including just educating the patients and families about addiction. We can provide referrals to evidence-based family therapy. We do determine whether a referral to a higher level of care is necessary and make those referrals. And finally, we offer addiction psychiatry consultation, which has been a really important part of our work. And I think is a perfect segue to transition to Dr. Tejani about what exactly this means and why it's really important. So I'll kick it off to Dr. Tejani. Thank you so much.
Thank you, Dr. Mesheriakova. So I'm going to be talking about co-occurring psychiatric disorders in youth who also have an opioid use disorder. The key point here is that the vast majority of young people who have an opioid use disorder also have a psychiatric disorder. About 80% of individuals entering treatment for substance use disorders in general have at least one psychiatric disorder. The number is higher for opioid use disorder specifically, and more than half of young people with any type of SUD have 3 or more co-occurring psychiatric disorders. So comorbidity is really the rule, not the exception. There are a number of reasons that comorbidity is the norm. Sorry, there's a little lag on my, thank you. Um, there are common factors that increase risk of both psychiatric disorders and substance use disorders, both genetic and environmental risk factors that contribute to the likelihood of experiencing one of these disorders at some point in one's life. And what this graphic shows here is that there's a general factor that is sometimes referred to as the P factor or psychopathology factor that is responsible for the overwhelming majority of the risk of developing any sort of DSM disorder, whether that's an internalizing disorder like generalized anxiety disorder or depression, or what we sometimes call an externalizing disorder like a substance use disorder or conduct disorder. Um, so there's a lot of overlap in the risk factors between all of these disorders. And when people come to treatment for one disorder, we need to think about the possibility of another disorder and screen and do some sort of assessment to be able to make that diagnosis if present. And this is just a question to ask you to think about what age group has the highest past year prevalence of a substance use disorder diagnosis. I know the poll feature isn't working, so I'll just ask you to make a guess on your own. Sorry for the delay here. I'm having a little bit of technical issue. Dr. Mesheriakova, are you able to advance? There we go. So the age group that's at greatest risk of having a past year substance use disorder that shows the highest prevalence of past year substance use disorder is the young adult age group, that group of 18 to 25-year-olds, sometimes referred to as transitional age youth or emerging adults. Teenagers are actually kind of grouped together with older adults as far as their past year prevalence of a SUD, but you can see that young adults have much higher prevalence of SUD than any other age group. And likewise, the past year prevalence of serious psychological distress is also greatest in this young adult age group, and it's actually been increasing quite a bit over the past 10 years. Fortunately, we have not seen that increase in past year prevalence with SUDs. They've remained relatively flat overall over the past few decades, but in regard to psychiatric disorders or psychological distress, we have seen increases. There are neurobiological and neurofunctional reasons for this high degree of overlap, and the fact that young people are at such high risk of developing and maintaining a substance use disorder as well as a psychiatric disorder is due to the common neurofunctional underpinnings of both of these disorders. So, nope, it's advancing for me, sorry. There we go. So what you see here are, it's a sort of an illustration of the 3 main neurofunctional domains that contribute to the risk of developing SUD and maintaining an SUD. And those domains are negative emotionality, so a propensity to more negative emotions, deficits in executive functioning, and impairments in incentive salience, which is just a fancy term for what sort of things do you prioritize? What sort of activities and behaviors does one find rewarding, desirable, and pursue? So adolescents actually have normal developmental vulnerabilities in all three of these domains. And certain adolescents have genetic or environmental factors that put them at even higher likelihood of vulnerability, or who have a higher degree of vulnerability in one, two, or all three of these domains. So you can see here in this graph on the right here that adolescents, their reward center is more fully developed before their executive functioning circuitry has fully developed. And because of that mismatch between drive and stop, put the brakes on, let's evaluate if this is the right behavior, they are more likely to do things that are stimulating or appear rewarding without thinking through the consequences and evaluating if it's really like a good decision. And from an evolutionary perspective, it kind of makes sense that this is the case. The adolescent years and early adulthood is the stage of life where one has to go out there in the world and try new things on one's own, find a mate, go live independently, procure food. So this was, really for adaptive reasons, most likely, but kind of because of an accident of nature, drugs activate the same circuitry that is involved in pursuing the basic necessities of survival. And young people, because of the way their brain is working at the stage of life, are at particularly high risk of continuing to use substances even when they cause harm. There are also some other differences that I won't get into too much, but adolescents are more likely to interpret neutral faces as fearful or angry, and they also have stronger and stress responses that take longer to reset to normal. And that also plays a role in the development of addiction and substance use. So hopefully I've convinced you that if you see young people in your office, you are definitely going to be seeing some people with co-occurring disorders. Young people with psychiatric disorders are at higher risk of developing a substance use disorder, and they are at higher risk of developing opioid use disorder if they're given an opioid prescription for any sort of medical reason. Young people who have substance use disorders are at higher risk of having a psychiatric disorder, even if they have yet to be diagnosed with it. And they also are more likely to not respond to treatment in the way that individuals without a SUD do. So they have higher rates of treatment-resistant psychiatric disorders. Youth with opioid use disorders specifically are more likely to have depressive symptoms. And I'm sorry, one second, I'm having a little, sorry about that. Distance learning. So youth with opioid use disorders have depressive symptoms at baseline, often before they have even begun using opioids, and the degree of severity of their depressive symptoms is correlated with the frequency of opioid use even before they've developed an opioid use disorder. Most youth with OUD have a co-occurring mood disorder, and they also have higher rates of risky behaviors in general, particularly risky sexual behaviors. And youth with OUD who have mood disorders, which is a fairly large group, they are at very high risk of opioid overdose. This is actually the second most significant risk factor for having an opioid overdose, just after injection opioid use. Youth with OUD compared to youth with other types of substance use disorders are more likely to have more severe depressive disorders. It's also important to recognize that in addition to the comorbidity between substance use disorders and psychiatric disorders, there's a tremendous amount of comorbidity between different types of substance use disorders. Historically, people have thought of individuals as gravitating toward one type of drug, but actually that's not really the case. While people may have their preferred substance that they use over others if available, the vast majority of people, especially young people, have polysubstance use. So they use a variety of substances. And there's likely several reasons for this, but one that the research has shown, particularly genetic research and twin research, is that there is a common liability to developing a substance use disorder in general, as a general disorder, more so than a liability to a developing or using a specific type of substance. And the type of substance use disorder that one develops has a lot to do with the environment and what one has been exposed to and what's available. I'm gonna try to go back one slide. Dr. Mesheriakova, can you go back one? There we go. I'm so sorry for these delays in between slides. There we go. So I just wanted to point out that while opioid use disorder in youth is a problem that will come up in most practices that treat young people, fortunately, it's not the most common SUD that we see when we work with teenagers exclusively. So it's important to think about how other substance use disorders or other patterns of drug use may later contribute to the likelihood of developing an opioid use disorder. And there's a very strong association between adolescent onset cannabis use, particularly heavy cannabis use in adolescents, and later risk of opioid use disorder. And there are a number of very well-designed discordant twin studies that show that there is a, to some extent, some causal association between adolescent cannabis use and later opioid use disorder. So just another question to ponder in your mind is this one of, for youth patients with OUD, is the presence of a co-occurring depressive disorder associated with worse treatment outcomes? Oh, could you please advance this slide? Oh, there we go. All right, so here's our answer. This is an area where our shifting has actually, or our thinking has actually shifted a bit over the years. Historically, adult data was kind of mixed. There was some evidence suggesting that adults with co-occurring disorders had worse SUD outcomes than those who did not have a co-occurring psychiatric disorder. But in youth, the research is much more clear, the evidence is much more clear that young people who have co-occurring psychiatric disorders, particularly a co-occurring depressive disorder, actually do better with treatment than youth who just have an OUD in the absence of a co-occurring psychiatric disorder. So there's a fair amount of evidence that the presence of a co-occurring psychiatric disorder leads to better retention in OUD treatment, that receiving ancillary treatment such as therapy and or medications for psychiatric symptoms is associated with less attrition and better opioid use disorder outcomes. Having a higher degree of depressive severity at treatment entry is actually associated with less opioid use during treatment. And the use of either medication for addiction treatment, such as buprenorphine, and or psychosocial supports for opioid use disorder is associated with better overall psychological well-being separate from the opioid use disorder. Now, unfortunately, in practice, this evidence is not used to the benefit of patients' care. There's sort of a disconnect here, and that for a number of reasons, perhaps stigma, perhaps lack of knowledge, lack of familiarity with this research base, people who come into treatment with co-occurring disorders, whether they're seeking care for their opioid use disorder or their psychiatric disorder, they often get worse care for both of those disorder. There's sort of a thinking that treatment won't work very well for these patients, and that's just not the case, as we just discussed. Recent studies have found that patients who come into treatment with co-occurring disorders are less likely to drop out, yet they are more likely to be terminated prematurely by the treatment center. In addition, patients with OUD who also have a co-occurring psychiatric disorder are less likely to receive medication for their OUD than those individuals who do not have a psychiatric comorbidity. And patients who have an SUD who are coming in for a depressive treatment are less likely to get the evidence-based or gold standard depressive treatment for their mood disorder. And a minority of residential treatment programs offer medication for addiction to begin with, particularly treatment programs for youth. It's very, very hard to find a residential treatment program or even an intensive outpatient treatment program for young people with OUD where medication is available. Another thing to talk about here is what do we do, even knowing that patients who have co-occurring disorders can benefit with treatment? What do we do if only one treatment is available? And because we all have probably experienced the difficulty in referring to patients to both addiction care and psychiatric care, wait lists are often long. I want to point out how to proceed if we are fortunate enough to get our patient into some sort of substance use disorder treatment. What do we do if they're still on the wait list to get into a psychiatrist? And by getting into substance use disorder treatment, I'm referring to even the ability to receive buprenorphine from their pediatrician or their primary care doctor in a general clinic, because that is addiction treatment. And fortunately, the research, thanks. I might just have you advance my slides, Dr. Mesheriakova, because it seems to be glitchy on my end. I'll let you know when to go to the next one. So fortunately, there's a recent study, it's kind of a small one, but consistent with other similar studies that took emerging adults or EAs and compared them to older adults and randomized a group into a group that was on a wait list to receive more comprehensive treatment, including psychotherapy and psychiatric treatment. And the other group was put into a program where they met with their primary care doctor once a month, received buprenorphine. There was some drug testing and a little bit of psychoed, but no formal counseling. And what they found in this study is that the young adults did just as well as the older adults, even when they were on the wait list for more comprehensive treatment and in the absence of any sort of specific psychotherapy or psychiatric treatment. At intake, the younger adults actually had a more severe presentation. They had higher rates of past year injection drug use. They had greater legal and psychiatric severity. Yet at the conclusion of the 12-week of buprenorphine treatment without psychotherapy, the emerging adult group actually had a greater degree of improvement in their depression scale and anxiety scores than the older adult group, and their opioid use disorder outcomes were exactly the same. So psychiatric comorbidity did not affect the outcomes here, even in the absence of an integrated psychiatric treatment. And while integrated care should be the gold standard, ideally patients will be able to get psychiatric care and addiction care at the same time. We shouldn't withhold care altogether if we're only able to get them one treatment to start. And here I just have a graph showing that young people with OUD who receive medication for their opioid use disorder are better retained in both their addiction treatment, and they're also better retained in their behavioral health or mental health treatment. Sometimes there's a sense of defeat, or a sense that young people can't be treated as well as older people for their SUDs, that their outcomes aren't as good. But this is not the case, and this is not what the evidence shows. Youth outcomes are actually just as good as adult outcomes if you offer youth-specific programming. So youth do have different treatment needs than adults, but if you get them evidence-based care, you get them the right care, they can do just as well. And those outcomes are similar to what we see for other chronic illnesses. It's important to remember that there are high rates of relapse when treatment is stopped. So people are likely to have a recurrence of their disorder if they drop out of treatment or if they are discharged from treatment. And this is similar to what we see with other chronic illnesses. I think sometimes the feeling that youth do not do as well in addiction treatment as older adults, or just sort of as well as we would like, has to do with the way that we think about outcome. There's a lot of different types of meaningful outcomes here. It's not a simple, are you using or not? It's not an all or nothing situation. There's a lot of evidence that just keeping someone in treatment is actually very helpful, and it is a meaningful outcome to think about. Um, there's one study here that I listed that looked at individuals who were receiving medication for their OUD, and looked at the group that stayed in treatment and found that being in treatment and coming to treatment more often than not was actually associated with a much greater quality of life or functional improvement than what the drug test showed. So people who had negative urine tests had less improvement in their overall functioning than the group who came to treatment more regularly, even if they still were testing positive for opioids at some point. So I just think that's an important point, that we want to look beyond just the urine test results, just the drug use, and think about the whole person and the big picture. It's helpful to just kind of step back every so often when working with your patients and look at their general trajectory and sort of, ask yourself, are things overall getting better? To think about those domains that Dr. Mesheriakova mentioned: work, relationships, school, general health. Are we seeing trends toward improvement? And if we are, that means we're probably on the right path, and we should feel good about what we've been able to do so far. Many teens do not have total and continuous abstinence. Relapse is common, but what we know is that the recurrence of the disorder goes down after each relapse, and the treatment does work, and there's a greater chance of more long-term recovery with each subsequent treatment, especially over the course of the lifespan. So I think it's helpful to think about one step at a time, and that we're laying foundations here, and every little bit of work and improvement really matters and makes a difference over the long run. There's a fair amount of research that helps guide us about what actually helps people get better and recover and have lasting improvement in their opioid use disorder. I've listed here sort of the general things to think about. Internal motivation to quit is strongly associated with better outcomes. Having an understanding of the impairment caused by one's substance use is associated with better outcomes, and having a sense of agency, a feeling of purpose, being involved in one's care, collaborating, having a collaborative treatment is also quite motivating. And then, of course, the family engagement piece is so important. A lot of times parents ask this question when they've brought their young person to treatment, because usually, almost always, with teenagers at least, they are not the ones picking up the phone and coming in asking for help with their drug use. It's usually the parent, and a lot of times the teen is reluctant to really even talk about what's going on in their life, and certainly is reluctant to admit that they have a problem. And so parents often will say to me, doc, doesn't he or she have to first admit that he has a problem and wants help? And parents will feel defeated right from the get-go, and may not be very motivated themselves to keep bringing their young person in. And so what I often tell parents, think about myself, is that the first step is really to help people even want to come to the appointments. And that's the first phase of this work. It's not immediately trying to get people better and seeing negative drug screens. It takes time sometimes to get there. And there's a lot we can do to help people actually want to get help and want to get better. And so we need to get our patients there before we tell them all the things they need to do to change. And it kind of makes sense if you think about it. It's hard to follow advice and make difficult behavioral changes if one does not see any benefit or reason to doing so. And, I think the most helpful thing to do practically with young people to kind of get them interested in coming to these appointments is to just ask them what they want to get out of the time they're spending with you. I usually start appointments with teenagers by saying something along the lines of, can you tell me what, if anything, you might want to get out of this appointment today? It might not have anything to do with the drug use your parents mentioned. I'm interested in other things too. And that's usually an effective way to engage the youth and to kind of motivate them to keep coming back and to keep talking to you and to engage in their care. Empathy and validating the young person's concerns is so important. These are some quotes from youth who were in treatment saying, what it was that they found helpful about treatment. And it was all really about being listened to, believed, not being judged, being able to talk about what's on their mind. And then, keeping in mind that psychiatric comorbidity, having a psychiatric disorder is a motivator.
Hey, see you later.
Treatment. So here I've summarized a recent study that showed that patients with comorbid depression did better in regard to their opioid use disorder, not because their depressive disorder improved. The degree of improvement in the depressive symptoms was not what mediated the better opioid use disorder outcome. It was just the fact that they had a history of depression. So again, this kind of makes sense. If you're not feeling good, if you're feeling down, you're going to want to get better. Most people want to feel good. And the goal of opioid abstinence at treatment entry, whether someone had that goal or not, was not at all associated with the OUD outcome. So this is really important. If a patient is not saying they want to stop using opioids, that does not mean they will not benefit from treatment. You can still help people who are coming in saying they have no interest in stopping their use. I'm going to go through a couple of these slides a little more quickly, but I'm happy to answer questions at the end. I want to make sure we have plenty of time for discussion. I just want to put out there that coercive approaches, like punitive approaches, ultimatums, are not helpful, especially not with young people. And there's even a risk of real lasting harm. We want people to come back to treatment whenever they need it. And if a young person is forced into doing things that harm them, that don't make sense to them, if they are not talked to in a respectful and sort of honest way, it's highly unlikely that once they're an adult, they're going to come back to a health professional because there's going to be a negative association. So we want to think about the whole big picture and the whole lifespan here. These are some reasons that youth reported wanting to get sober, to stop using. It's really, again, about agency and about being able to achieve the goals that they have personally identified. So things like, showing themselves they can do it, that they aren't addicted, wanting to save money, wanting to feel more in control of their life. And then the least common reasons for wanting to come to treatment were things like a loved one telling them they should go to treatment or getting a special gift for quitting. But unfortunately, a lot of times doctors and parents are more on this side, the right side of the picture here, and we're not thinking enough about the other things that actually matter to these young people. Maybe we'll come back to this one during the discussion if people are interested. I can't emphasize enough what Dr. Mesheriakova already touched upon, which is we have to engage parents and family members in treatment. Far too often, there's a reluctance or hesitation, especially with therapists, to include parents and to have them come to sessions with the teen or even separate from the teen. I think there's a worry that it may damage the alliance with the teenager. And rarely does this happen if it's broached in the right way. So there are ways to help teenagers want their parents to come to treatment. And if you sort of bring it up in the right way and reassure the young person that you don't want to make their life worse, you want to make their life better, you can then help them connect the dots as to how having their parents more involved in their treatment could be helpful. A lot of times, parents are doing the best they can, but they don't necessarily have the knowledge for what really works to motivate their young person and to help them feel better. So we can work with them to create a dynamic in a situation at home that allows everyone to have a healthier life and to feel better and to feel more satisfied with treatment. There are confidentiality concerns to consider. We can talk about this in the discussion. The legal issues can be a little complicated and are variable based on the setting and state in which you work. And they may not always line up with clinically what is indicated. So it's important in your own mind to kind of think about clinically what's the right thing to do here. And then you also, of course, need to consider various legal duties. It's important to be very transparent from the get-go with both youth and their parents about how confidentiality works and to check in about this often. And then lastly, as we wrap up, what do we do when patients are not following our recommendations? This happens all the time, of course, in medicine, but it comes up a lot in addiction treatment, especially when working with young people. So it's important to remember that kicking people out of treatment doesn't get them better. If you're not coming to treatment at all, it's highly unlikely that you're going to do better than if you're in treatment. Relapse rarely should be a reason to terminate someone from care. It probably never should be a reason to terminate someone from care. It may signal a need for a higher level of care and for a referral, or perhaps just an adjustment in the current treatment plan. When people are not following our recommendations, there's usually a lot of reasons why, and those reasons usually are not that they don't care or they don't want to get better. Because again, most people want to feel good and want a happy, healthy life. And I also just want to put out there that there's no one size fits all approach here. Everyone's path to recovery is different, so we have to be flexible and collaborative when making recommendations. There's several different reasons that one might refer a patient to a higher level of care. I've listed a few here. Really, if you've been working with someone for a little while and they're not improving or they're worsening or there's an imminent safety issue, those are good indications for getting a more specialized team involved. And or if the parents are not on board or there's a high degree of conflict or safety issues in the home, that would be another reason to get a specialist involved. All right, that's the conclusion of our didactic portion of the talk. I think we're going to transition here to a discussion for those of you who are still with us.
Just wanted to really say thank you so much. This is such a lovely and comprehensive presentation, and really just summarizing that opioid use disorder is still significantly prevalent and that the severity and the risks of this are very high, and it's very often under-recognized and undertreated. And really framing this as a neurodevelopmental disorder, that natural risk-taking that adolescents normally engage in that's developmentally expected during adolescence, especially when primed by relative alterations in their executive functioning, or maybe a tendency to interpret things a little bit more negatively, and less rationality in their wanting, the immediate rewards of substance use, and how this is, really a prime setup for developing a substance use disorder. And really wanting to appreciate the importance in the treatment and engagement overall, that they're, looking at the big picture and taking kind of the longer road approach. And this, I think, seems to be in contrast to some of the earlier teachings that, recommend a more binary, like if you've relapsed, then, X pathway needs to happen. And really underscoring the importance of voice and choice, in particular of the teen, and having individualized treatment approaches. And then the really significant importance of having the family integrally involved throughout. I wanted to go into some of the questions. So there have been multiple requests for sharing the slides, and I'm seeing yes nods from our speakers, which is great. So we will work to share those. And then some questions as they have come in. So one is for Dr. Mesheriakova, what to do with a positive craft. And the context for this was also a little bit around, the relative lack of resources and places to refer people to. And, I think the premise that if you screen for it, then you're obligated to treat it. And so wanted to hear your thoughts on that.
Great question. It comes up really frequently. It's also the same question that comes up with depression screening for adverse childhood experiences. And a lot of people are really afraid to screen because they don't feel adequately prepared to address the issue. So I would say, it's it can be a complicated answer, but I would say if you have a positive craft, the next step really should be determining whether a substance use diagnosis is present. Because that's really what we're looking for. And, just like in many other illnesses, if we don't make a diagnosis, it's really hard to prescribe appropriate treatment, right? So, and the thing is you may not be the one to make that diagnosis, and it may not happen in that visit, right? So even in our adolescent medicine clinic, where we do get more specialized training in diagnosing use disorders, we may not be able to make that diagnosis in one visit, right? So we may have a positive craft during an annual physical, but we don't have time to address it that day. I think the most important thing is that please remember to use your follow-up resources, right? So a lot of pediatricians are so used to saying, okay, you did your annual physical, great, see you next year. For kids with positive crafts, definitely just schedule a follow-up, maybe in 3 to 4 weeks, maybe in 2 months. And then really spend that time when they come back speaking to the kid and to their caretakers if possible, to really determine if their substance use has impacted those important domains of family, occupation or school, and recreational activities. And of course, if in doubt and you're really inundated and you're really busy and you don't feel prepared to really determine that diagnosis, think about referring them. And, of course, all of you are welcome to refer to our program, the UCSF Youth Outpatient Substance Use Program. Everything we're doing right now is actually via telehealth. So even people who are far away, we've been able to get them seen via telehealth. The other option is adolescent medicine is a specialty that a lot of people don't know about, but often adolescent medicine providers have special training in, some mental health issues, including substance use. So if you have an adolescent medicine clinic close to you, that may be another referral option. Dr. Tejani, anything you would add to that?
I was just going to add that it can be difficult as a physician to, not know if something bad might happen with your patient if you don't do more in the moment. I mean, all of us are in this profession because we want to help people, be healthy and have good lives. But I guess I just wanted to put out there that fortunately, most people are not in a imminent safety crisis situation. Sometimes they are, and we don't know it. It's really hard to predict these things. So, I would just kind of think about this idea of laying one brick at a time, and usually doing something as long as it's evidence-based is the right thing to do. And there are ways to be helpful without offering every treatment modality at once.
Great.
And just to make explicit, your thoughts on kind of more consultative, collaborative relationships between specialists like yourselves and then primary care providers, and having kind of a, back and forth or combined treatment approach that involves some consultation with you, establishing, the diagnosis, and then being able to consult as necessary.
Yes, never worry alone. That was my fellowship director's motto. Yeah, call a friend.
And in California, actually, we have the substance use warm line. It's not a hotline, it's a warm line. And it's actually available nationwide. And people who have questions about what do I do with a patient who's struggling with substance use, anyone can dial that warm line, and we can provide that number, offline to people. And that's one way to get connected to providers who may have more experience in treating use disorders as well.
That's great. And I just want to acknowledge the person who typed into the chat that family medicine providers who see adolescents and are comfortable treating OUD are also a great resource. So wanting to move on to one question that had come up was cannabis as a harm reduction tool in long-term or severe OUD. And that question is for Dr. Tejani.
Yeah, great question. So there's actually no good evidence that cannabis use in any form improves OUD outcomes or is even effective as a sort of harm reduction strategy. There was a paper in JAMA a few years ago that showed states with I can't remember if it was recreational or medical marijuana, but that had some form of legal marijuana had lower opioid overdose deaths. And there was a lot of discussion and speculation about whether cannabis is effective as a harm reduction strategy. But there was a follow-up to that was just published this year that actually found that the association there had nothing to do with people actually using cannabis. It was more about treatment services and other factors that might be available for OUD in states that had more permissive cannabis policies. There were other things too, but it essentially debunked the theory that cannabis use reduces opioid overdose. And actually there's other research that shows co-occurring substance use, whether it's cannabis or other drugs, in addition to opioid use disorder, increases harm from OUD.
Thank you. Another question, this is for Dr. Mesheriakova. Do you ever use naloxone or recommend naloxone for parents?
Absolutely. I love that question. Whenever we talk about naloxone, I make sure that the kid has some, and that any caretakers, or even, if they have a close friend, I will prescribe to the target patient, several naloxone, medication packages to give to their friends, because obviously people administering naloxone, they're not going to be able to do it themselves if they're in the middle of an overdose. So really instructing their friends and family members in how to use that is critical. We have had some interesting confidentiality discussions about that, where we've had youth who, maybe have used opioids or other drugs that their parents aren't aware of, and they don't want us to disclose that information. And, after we do a really thorough assessment for imminent danger, we decide not to sort of break confidentiality. How do you prescribe naloxone and make sure that the parents have access to naloxone while also maintaining confidentiality has been really interesting. And so in our clinic, we basically just give out naloxone like candy. We just say anyone who comes to our program just gets naloxone. If it's not for your kid, it's for a bystander on the street. So we kind of have this covered policy of everyone should just have naloxone in those instances, but it can get a little bit awkward.
Thank you. Next question is it came up during Dr. Tejani's presentation, but I think, potentially for both of you, any peer-reviewed research that you're aware of on ibogaine treatment?
On what?
Ibogaine treatment, and I'm personally not familiar with this, so I'm not sure if I'm saying that correctly, but Ibogaine.
South American plant. I'm not familiar of any specifically for opioid use disorder. Are you, Dr. Mesheriakova?
So definitely not for adolescents. Let me see. So I thought ibogaine was, yeah, it's not something I'm as familiar with, to be honest, as far as evidence-based research. I've heard things here and there, but I can't quote any papers, but I will put that on my to-do list.
And then next question is routine use of motivational interviewing to determine readiness for treatment. And maybe we'll ask you, Dr. Mesheriakova, to answer that first, given that you're in primary care.
Yeah, absolutely. Motivational interviewing is an everyday occurrence in our clinic. I advise everyone to get as many hours of training in motivational interviewing as you can, because we know that after training, we tend to do a good job, but about 3 months later, our skills tend to get a little rustier. So getting repeated treatment in motivational interviewing is something I would recommend for everybody. And for sure, when working with adolescents, the vast majority of adolescents who come to our substance use program don't really want to be there. They're usually brought because their parents are concerned. And so we really use motivational interviewing to build that internal motivation with adolescents as we work with them.
Yeah, and I will just add that there's a lot of evidence that motivational interviewing is an effective way to keep people in treatment, to get them actually like actively involved and engaged in their treatment and improve their outcomes. And on one of my slides, I didn't touch upon it due to time constraints, but there was a little note about how psychoeducation alone, in the absence of other approaches like family therapy and motivational interviewing, is not effective. And there's even a little bit of evidence that it might worsen outcomes. But I want to make sure to mention the caveat that if you combine it with motivational interviewing and with family therapy, then there may be a role. And I think the idea there is that you have to make people believe that the information you're telling them is personally relevant. You have to connect it to their life in some way. And this is where motivational interviewing is so important, because it makes the treatment individualized for the patient.
Great. And just thinking about the readiness for treatment and then some of the psychoeducation, there was an early slide that talked about, some psychoeducation. I'm wondering if you have any good resources or tools that you like to use to provide that psychoeducation routinely.
So personally, I don't have something manualized I use. I try to tailor it to the individual patient. And often the tailoring involves understanding why they use substances. I actually encourage people to ask young people and do it with the open mind, so what do you like about that? What does it do for you? Because that's actually a very good way to figure out what may not be going so well in their life. And then to get your patient to a place where they may see the difficulties is somewhat connected to the substance use, but not only there because of their substance use, because usually the difficulties were present to some degree beforehand. And so I'll bring in evidence I'm familiar with based on what is of interest or problematic with my particular patient. But there's an online tool, I think, for cannabis use disorder, specifically in adolescents, that is a combination of motivational interviewing and psychoed that has some evidence. I can share that later.
One paper that I often refer to, there's a 2017 report by the Academies of Science, Engineering, and Medicine on cannabis specifically, because I would say the vast majority of kids who are brought to addiction treatment, it's for cannabis use. And this is a really nice report. It basically did a review of the most recent literature about everything there is to know about cannabis and what it's sort of thought to be useful for and all the things that it's not useful for. And some of the most common things that I quote from that paper is that there's a moderate association with chronic cannabis use and increased rates of suicidal thinking, suicide attempts, and suicide completion. So a lot of the kids who we see who say they're using cannabis to treat their anxiety or their depression, who have had suicide attempts or suicidal ideation, for me, that's a really important piece of data to share. And of course, it also talks about the very robust evidence for the connection of chronic cannabis use in psychotic disorders as well. So we certainly have a number of youth who have co-occurring psychotic disorders. And we've seen youth who have had, substance-induced psychotic disorders. So that's a discussion.
And then some of the other questions that we've had are, so one that just came in is, can we know what you've heard about ibogaine treatment?
The only, I've heard of some studies looking into ibogaine treatment for opioid use disorder in European countries, the outcomes of which have been mixed from what I've heard. So that's my knowledge on ibogaine at this point is pretty limited, I would say. I just know it's something that has been more researched in Europe. I don't know, Dr. Tejani, if you've heard anything else.
Yeah, I'm more familiar with some of the research looking at that substance and some other related compounds for alcohol use disorder or for treatment-resistant depressive disorder. I just have not seen, at least not that I can recall, a study looking at opioid use disorder specifically.
Okay. And then another kind of minor clarification was for Dr. Mesheriakova, clarification on the MAT, who sought MAT after actually received the treatment, or how many persons overall. And I don't know if you had seen this question.
I think that was referring to the paper by Chatterjee et al. About overdose, the Massachusetts study where it looked at everybody who came to treatment for opioid overdose and how many of those actually got medication treatment for addiction. So the 8% number was the number of adolescents aged 11 to 17 that received medication treatment in the 12 months following that medical encounter for severe opioid overdose. It does not specify whether these youth were or were not seeking pharmacologic treatment. My thinking on that is that if a youth comes in to a hospital for an opioid overdose, they should absolutely be connected with a treatment program. So I would say 100% of those youth should have been connected to a program that could offer them MAT. Whether that happened, I'm very doubtful. But what I actually see happening pretty frequently is that even youth who come into a hospital with an opioid overdose, they get sent out with really nothing. So I have a patient in my practice who 2 years ago came into our ER, and the note literally said, patient does not think he has a problem. He was sent home with no naloxone, no treatment resources, no referrals, nothing. And unfortunately, I think this happens not infrequently.
Just acknowledging the time, and that in addition to the multiple requests for the slide decks, we've gotten some requests for the specific references that you've alluded to, and also some of the resources, in particular in different geographic locations. And so we will try to compile those resources and share those with this group. And so with that, I want to thank everyone for your attention and for this wonderful and rich discussion. And I think this is perhaps the first of many to come. Thank you all.